why go through acute confusional states? Well, what we're going to do is go through what an acute confusional state is. It's not what you're feeling at the moment. Go through how we pick them up and how we can manage them, and then a bit on the ethics and law at the end. So, this is a good lecture for now because acute confusional states are really common. As it says there, about 20% of inpatients will have an acute confusional state at some point. If you're on a care of the elderly ward, I guarantee that's a lot higher. And also, it's good general medicine. It has so many causes. It'll get you thinking about all the possibilities behind that patient. So, the old term was delirium. That's what kind of the term acute confusional state has started to trump. And what is it? It's this. So it's an acute, fluctuating, and reversible change in someone's mental state. And it's these key words that kind of separate it from the dementias. So it's acute, whereas dementia is obviously chronic. It's fluctuating, so you might see the patient in the ward round in the morning and they're really zoned out, they're really confused. You'll go back to them in the afternoon and they'll see a different person. So it's not a set level of confusion, it fluctuates. And it's reversible. It's based on a reversible cause. There's something that's happened that's caused the confusion. If you treat that confusion, that underlying cause, then you will hope to reverse the confusion. This is a nice way of thinking about it in terms of an acute brain failure. We often think about people coming into hospital with an acute heart failure, with acute respiratory failure. Acute confusional state is effectively an acute brain failure. Something's going on in that body that has overshot the threshold that the brain can manage, and it's just portraying that in one way or another. There's two major types. So hyperactive. These are the agitated people. They're restless. They won't sit still. They're up and wandering around. You can get a hypoactive state where they're withdrawn, they're quiet, they're not answering you, they're really sleepy. Or you can get a mixture of the two. As I said, it's really common, it affects a lot of people, and it has big impacts. It affects mortality, it affects morbidity, it increases lengths of stay, and in an obvious consequence of that, increases the cost for the NHS. What are some of the signs that we can think of? It's all of these things here in the handy acronym of delirium. So disordered thinking, that's probably what we think most about when we think about confusion. A euphoric fear or depressed or angry, what that means is there's a change in the person's mood, or there can be a change in the person's mood. They might have language impairment, they might not be able to communicate very well. They might get psychotic symptoms, they might have hallucinations and delusions. Not all psychoses are schizophrenia, it can just be a representation of an acute confusional state. This is quite a classical sign that you'll see is the reversal of the sleep-wake cycle. And when you start doing night shifts, and if you've done night shifts already, you'll go onto the medical wards and you'll see people up and reading the paper at 3 in the morning and wandering around the ward. You'll go back to them in the morning ward round and they'll be zonked out and asleep. That kind of classic awake when they should be asleep and asleep when they should be awake is quite classical of an acute confusional state. Not helped in many hospitals by their observation units being in the depths of the hospital with no windows, so you can't even tell what time it is half the time. Inattention, so they're easily distractible, they're not giving you their full concentration. They might be disorientated and unaware of where they are, and they might have memory deficits, not remembering who you are or what's happened. So they're the kind of classical things that we would look for, and sometimes they're quite obvious, sometimes they can be a bit more subtle. How do we diagnose an acute confusional state or delirium? So the NICE guidelines recommend using the confusion assessment method, which is linked with the DSM criteria, which I'll bring up in a second. But the confusion assessment method is basically these statements here. So to say someone's got an acute confusional state, so their confusion has to be of an acute onset, it fluctuates, they have an element of inattention, they have an element of not giving you their full focus, and then they can either have disorganized thinking or they can have an altered level of consciousness. So effectively, if you've got 3 of those 4 things, that's an acute confusional state. And there's lots and lots of things that you'll see how that can fit into it. They're basically a brief summary of the DSM-4 diagnostic criteria, which obviously, as you can see, goes into a little bit more detail. But the CAM is what we can use in clinical practice. Just a nice table to get your head around the differences between a delirium and a dementia. Most of it is fairly common sense. But the things that highlighted in that definition of acute confusional state are the real things to take away, and that it's acute, it fluctuates, and it's reversible, which is obviously the opposite of dementia. So we're going to just work throughout this lecture with a few cases and just think about what the causes could be and think about the possible management options that we might bring in. So the case one is Dorothy. She's an 87-year-old lady who has been an inpatient for 4 days after having a fall and fracturing her neck of femur, and she's had that repaired. Her family are concerned that since the operation she seems a lot more confused than usual, and she keeps seeing her deceased husband at the end of the bed. Is this an acute confusional state? Would we be happy with saying that? Yeah, absolutely. And what are some of the causes here that we think could be contributing to Dorothy's change in mental status? Pain, I heard. Yeah, pain, absolutely.
Drugs.
Drugs? What sort of drugs? Say again. Yeah, it's likely she might be on opiate analgesics. Unfamiliar environment, absolutely. It's an often forgotten thing that actually if you put someone in a strange environment that they're not used to, that can in itself be quite a daunting experience and make them confused. Okay, they're dehydrated, yeah. So is she drinking as much as she needs? Okay, there's a few differentials there. So case 2 is Justin. He's an 18-year-old boy who was brought to A&E at 2 a.m. on a Saturday night by his friends. They say they've been out drinking, but he seems more drunk than he would usually be at this stage of the night. He's getting increasingly drowsy, he's incoherent, he's disorientated. Is that an acute confusional state? It is, isn't it? It's acute onset, he's fluctuating, he's got inattention, and he's got a decreased conscious level. It meets the CAM assessment of an acute confusional state. So what could be some of the causes here?
Head injury.
Head injury, you may have fallen over. Hyperglycemia, yeah. Well, I didn't hear that last one. Alcohol, yeah, a few too many Jaeger bombs. Other drugs, he may have taken other drugs, indeed. And case 3, so Craig is a 34-year-old man who was day 1 post an emergency strangulated hernia repair. And the nurses are concerned that he's very agitated and is threatening other patients. Anything in particular here? So it could be a lot of the same stuff as Dorothy, couldn't it? It could be having too much pain, could be dehydrated, might be a side effect from all the anaesthetic. Anything else that anyone might think about?
Alcohol withdrawal.
Yeah, withdrawal. You know, is day 1 of admission, has he not been taking something that he would usually take? Is he normally on antipsychotics or something, and he's not taking the medication that he would normally do? That's quite a typical thing that you need to be aware of when you're admitting a patient. Or seeing them on kind of day 1 or 2. And basically you're pretty safe in saying anything that you can think of can cause an acute confusional state. This list, you know, as you can see, is really, really extensive, and pretty much everything you could think of is on it. Obviously the common ones that we see a lot of in hospitals are the infections, so people coming in with UTIs, pneumonias, maybe they're in sepsis, maybe they're not, they don't have to be in sepsis, but all of those things will predisposed to an acute confusional state. As we just touched on, withdrawal from medications, whether prescribed or not. Acute metabolic disturbances, we've already mentioned hyperglycemia, but as you can see, a lot of other things, so uremia and acute renal failure, hypercalcemia, hyponatremia, all of those will cause confusion. Trauma, we've said about someone falling over and hitting their head, and the list goes on. Probably no surprises there, but, you know, you have to be really broad in your thinking when you're faced with a confused person about thinking what could be the cause for that patient. And how do we formally assess it? So we've said about the confusion assessment method as a criteria to meet, but how do we fit people into that? So obviously history is key, and often with confused patients you need a collateral history, whether that be from a relative, whether it be from a nurse from the nursing home, whether even in the middle of the night, have they got any old discharge summaries or something on the system that you can see what their baseline was. We can utilise other cognitive assessment tools. So the AMTS is the 10-point questionnaire, which I'll bring up on the next slide. It's probably well worth you trying to remember that for the exam. It's a useful thing to have in your back pocket to ask. You'll definitely need it when you start clerking patients into hospital. The MMSE and the MOCA are longer ones that we'll touch on in a second. If patients are unwell, if they've got decreased consciousness, then you need to assess them, as we discussed last week, by the ABCDE method. And then other things that we've been going on about all over the course. So looking at their drug chart, especially if they've been an inpatient for a few days. What are they taking? Are they on high-dose codeine, or what are they not taking? The pharmacist, if they've been there for a few days, will have written all the medications they're normally on. Have we actually made sure that we've written all of those up? Check their observations. Are they hypoxic? Are they hypertensive? Are they febrile? Are they hypoglycemic? If you're worried about an infection, do that infection screen that we've talked about, doing a urine dip, doing a chest x-ray. And then looking at other things such as their electrolytes, their TFTs, thyroid function, and their hematinics. As you remember from that list, B12 deficiency, folate deficiency can all contribute to a confusion. And obviously not forgetting their glucose. And this is basically a confusion screen. So you'll hear on ward rounds, especially care of the elderly ward rounds, has the confusion screen be completed for this patient? And basically that is the checklist of a confusion screen. There's two other things that you might consider. One is a lumbar puncture if you're worried about an encephalitis or a meningitis, and then CT head. So just CT head, putting everyone through a CT scanner with confusion has a really low yield. It's not been shown to be useful as a core assessment of confusion, unless there's any of these things here. So if they've got any focal neurology, if there's a history of a fall, and by history of a fall, they may have fallen, unless you're sure that they haven't hit their head in that fall, then you should be considering doing a CT to make sure they don't have a subdural hematoma. And it doesn't really matter when that fall is. If it hasn't been assessed, they may have fallen 2 weeks ago. Subdurals can grow really, really slowly, and this might just be their presenting confusion for that fall 2 weeks ago. So make sure you take a clear history and do a CT if you're worried. Or if there's any signs of raised ICP, so it might be focal neurology, but it might be Cushing's sign or vomiting or any of the other features that you'll be well aware of. These are some of the assessment methods that I've touched on. So the MMSE, the Mini Mental State Examination, was probably the most widely used when we all started medical school, but there's now a charge associated with it, so a lot of hospitals aren't using it anymore. Some are using the MOCA, which is the Montreal Cognitive Assessment, slightly more detailed, slightly more funky things on it. That obviously takes longer to do. It's not something you're going to be doing in the midst of A&E or in the middle of a ward round. No doubt many of you have been asked to do them because it's a good job for a medical student. But that obviously gives a broader view of that patient's cognition. The useful one that if you can try and learn it will be good is the AMTS, the 10-point one. A lot of clerking pro formas in hospitals will have this in now, and most places it's a requirement if a patient's over 65 years old that you do this on admission. Not necessarily because you think they're confused then, but then if they become confused in the admission, you knew they scored a 9 when they came in, and now they're scoring a 6. That's quite a significant feature. It can look daunting, but a lot of the questions are just about that patient. What's their age, what's the year, where are they, what's the date and time now kind of thing. And then the others is just a few pub quiz questions. Who's Prime Minister, when was World War I or II, and then can they count backwards from 20 to 1. So actually, when you think about it, it's not actually that difficult to try and remember. We worry generally if it's less than 8, so 7 and below is classed as kind of a significant score. Some common medications that are associated with delirium, we've obviously already touched on the opioid analgesics, but there is actually quite a wide range, ones that we might not always think about, like beta blockers and ACE inhibitors have been shown to contribute to delirium. So going back to our cases, so case 1, Dorothy, we've spoken to her family in a bit more depth. So she's normally independent, she lives alone, has, and is high functioning, she's independent of ADL, she does her own shopping, washing, cleaning and cooking. She's a non-smoker and she normally took some regular cocodamol for some arthritis pains. Her observations are there, pretty happy with those. The wound site clean, but you notice that she has actually got a bruise on the back of her head, and there's no other changes really that you can pick up from admission. Her bloods that were taken in the morning shows some raised white cells, mildly raised sodium, and the urea and creatinine are there, and you do a urine dip which shows that. So what things from that kind of stand out as potential causes? Yeah, a UTI. So we've got a nitrite and leukocyte positive urine dip, which is quite a strong indication for a UTI. She might not be able to give the classical history of dysuria and polyuria, but that was quite significant finding. Yeah, so she came in with a fractured neck of femur. There's nothing to say that she didn't hit her head during that fall, and actually we've now looked and there's a big bruise on the back of her head. That, you know, as we said before, would warrant doing a CT head in this patient. And this, you know, these are based on kind of cases I've seen. We had a patient on the care of the elderly ward that had been sitting in that ward for two weeks, and it was only 2 weeks in they had a CT head and showed that they had a subdural. So it is important to always, you know, go over and make sure that you're happy yourself that you haven't missed something. So yeah, we worry about that. Any evidence of any other things that we mentioned earlier? Yeah, it's an AKI, so the urea and creatinine's up. The sodium's marginally up again, which would all kind of make you think that there's she's dehydrated. And we've said, you know, other things like just being in hospital, major surgery in itself could throw people off. Good. So Justin, his friends think he might have type 1 diabetes. They say he often injects something into his leg. They think he might have epilepsy as well, but they're not sure. His observations are generally stable. He smells of alcohol, but his GCS is 12/15, and his ABG is there. So things that stand out there. So he's hyperglycemic, glucose is 1.1. That would certainly explain the confusion and the drop in GCS, so we'd want to treat that. We'll come on to that later. With this history, with the epilepsy there, he might be post-ictal as well. He may have had a seizure that his friends didn't notice or something. Maybe he's got a toxicity from one of his medications. Good. And Craig has no next of kin that you can speak to, but the patients in his bay say that he's been vomiting and getting agitated all day. His last observations that he'd allow anyone to do, really a bit tachycardic, but nothing much. He's tremulous, he's sweaty, and he's not letting you examine him. And then he starts physically attacking one of the other patients. Yeah, is it delirium tremens, as we said? Is this guy withdrawing? It would kind of fit that picture as tremulous, sweaty, agitated, day one of admission. It could still be any of the other causes as well, but you need to make sure that would be the major one that you'd be wanting to rule out there. So we'll come on to how we would kind of counter some of those things. So a really important thing underlining all of this is environmental factors. We've said, a colleague over there said about just being in a hospital, and it's a really underrated part of that. It can be really confusing and disorientating for patients to come into hospital. So just simple things about putting them in a good room with windows, having a clock and a calendar, just so they know what time of day it is and what year it is, can be really useful. they're going to be there for a while, bring in some home comforts. Can we get some photos of their family, some ornaments from their living room, so they have some familiarity and they recognise certain things in the room. And if possible, try and get a family member there present for as much time as possible, just to kind of reorientate them. If possible, having staff consistency, so there's always the same nurse working with that patient, so they get to know someone and not having to learn lots of people's names. Obviously, in certain areas, certainly around here, using health advocates. So if English isn't their first language, you can understand how it can even be more disorientating. And they might have spoken English at some point, but they actually, when they have an acute confusional state, they might actually just revert to their mother tongue, which can obviously make things as hardest. So making sure you've got interpreters on board, health advocates, to try and help you. Simple things like temperature and lighting, and they say single rooms if possible, just to make it easier to manage. And a lot of these things can be done as prevention. You don't have to wait until someone's confused to bring all these things in. In an ideal world, these should all be there really anyway. But certainly they should be in place if you've got a confused patient. The management, treat the underlying cause once you've found what it is. And the big thing is to try and avoid the use of sedatives. You will definitely be called overnight because the nurses wanting you to come and prescribe sedatives for the patients that are wandering around the ward. Happy wanderers don't need sedating if they're doing no harm to anyone. It's pain. It's time consuming. It's annoying to keep ushering them back to their bed, but they're not doing anyone harm, and you should try and stand your ground to not sedate those individuals. Sometimes they are a harm to themselves, sometimes they are harm to others, and in those situations, these are the options that we use to sedate. So typically a low dose of a kind of relatively short-acting benzodiazepine, such as lorazepam. Some of the antipsychotics, such as haloperidol, is the other big one used. I think more people are favouring lorazepam now because of the side effects that are associated with haloperidol. And then you can bring in other atypical antipsychotics, but you're generally going to get a specialist to advise you when you're getting to that. Always start with low doses. You don't want to have an agitated patient and then you give them too much benzodiazepines and then you drop their GCS and then have to put out a respiratory arrest call. So just start low and titrate up to get that patient to a comfortable level. I'm just going to bring these slides up just as a kind of a reminder, really. So the Mental Capacity Act governs, as the name suggests, people that might lack capacity. It's different to the Mental Health Act, which is, the sections where you section someone to bring them into hospital. That's to do with mental health illness. There might be a crossover, but the Mental Capacity Act is just dealing with capacity. And it's based on 5 major principles. So one is that capacity is presumed. You have to prove someone doesn't have capacity. And individuals should be supported to make their decisions. So, that is getting the health advocates involved if they don't speak your language. People that might not be able to communicate very clearly, it's finding a method to be able to communicate with them. As you'll all know, their decisions can be unwise, and presuming that you've proven that they have capacity, then you have to take what they say as what they want. If they lack capacity, you always act in their best interests, and you always use the least restrictive option. Capacity is decision specific, and these are the 4 main things that you need to have capacity. So you must understand the information, you must be able to retain that information, you must use that information to make an informed decision, and then be able to communicate it. So that's, shows the importance of giving the information, then asking that patient to repeat the information back to you. Have they actually taken on board what you've said and are able to retain it and feed it back to you? Because if they can't, then they're probably not going to be able to retain it long enough to make an informed decision. And then to communicate the decision is obviously a really important feature. If someone's unconscious, they're not going to be able to communicate it, but perhaps they've had a stroke and they're conscious, they understand what you say, they just can't speak. And then you need to try and go out your way to find a way, whether it be with picture charts or blinking or something, to understand that patient and allow them to communicate their wishes. So some other related acts that you'll see is the deprivation of liberty safeguards, the Dole's assessments, and effectively deprivation of liberty is only allowed when you're trying to prevent harm to a patient or to others. and it has to be proportionate. So, and this is actually, it covers more things than you might think. So, a patient that's wandering around the ward and is trying to leave the hospital, if you close that door and don't let them out, that is a deprivation of liberty. Hospitals are not prisons. If you or I were unwell, we'd be able to get up and walk out whenever we wished. So if we're keeping someone in hospital who's trying to leave, that is a deprivation of liberty. Simple things like putting the bed rails up on the bed for a patient that can't take those bed rails down by themselves is a deprivation of liberty because you're confining them to a cot, effectively. So just simple things like that can be a deprivation of liberty. And if you're doing those things, then you need to make sure that it's justified and validated, and it should be an MDT decision that is appropriate for that patient. Obviously, you'll know that people can make advance directives to govern decisions in the event that they lose capacity, and they might appoint a lasting power of attorney to make decisions about that. It's worth remembering that there's two types of powers of attorney. So there's one that covers financial, and there's one that covers health. So obviously someone may have been granted financial power of attorney. That doesn't necessarily mean that they have the power to make health decisions for that patient. And if it's really difficult or the patient has no next of kin, then you can bring in IMCAs, Independent Mental Capacity Advocates, who are just neutral professionals that every NHS trust will have, that can come in and act as a neutral representative for that patient to make sure that any decisions being made are reasonable and not controversial. So just quickly, before we finish, just thinking about our patients here. We've already covered Dorothy to quite a good extent, so we're going to be wanting to stop that coconamol. We want to give her some fluids, and arguably you could say she's septic here, so we'd want to give her some good antibiotics, give her fluids, try and orientate her in good nursing care. And the CT head that I forgot. For Justin, so we want to reverse this hyperglycemia. That's the most important thing here. How would we reverse his hyperglycemia? So GCS 12 out of 15, so he's there, he's just confused, he's not listening, he's a bit drowsy. Yeah, so you might be able to get some mucor gel. It's a thick glucose gel that you squeeze under the tongue. It just gets absorbed. You might be able to tolerate that. Alternatively, give them a bolus of IV dextrose, 10-20%. Try and avoid 50% because it's quite an irritant. As we touched on last week, what wouldn't be much use in him? The glucagon, yeah, because if it's related to his alcohol, that inhibits gluconeogenesis, which is obviously the way glucagon works. So you'd be wanting to use dextrose or the glucogel. Good. And for Craig, what would we do in the first instance? So he's attacking another patient. Yeah, you'd certainly call security 2222 or 4444, or there's red buttons generally on most wards. And then be thinking about, yeah, so you'd certainly be considering sedation in him, wouldn't you? So if you might try and talk him out of it, try and get in the way, and talk him down, ask why he's doing it, does he know where he is? That might be enough to settle him. It might not be. You might need someone to restrain him. Again, this has happened to me. A patient started strangling another patient. I didn't wait for security in that instance, but I don't know if that's legal. I don't know. But you have to. Communication wasn't going to work in that instance. And then you look for sedation. With him, as we said, it sounds like it's probably alcohol withdrawal. So if there is, then we need to be thinking about giving him chlordiazepoxide or diazepam, which are generally the preferred benzodiazepines, and then giving him Pabranax. Yeah. So anyway, prognosis is generally quite good if you get on top of the underlying cause, but the symptoms can last a lot longer. So you might treat the UTI, but they might actually continue to have some confusion for a few weeks, and it's worth telling the family that. And there might be a residual deficit. Someone that has multiple bouts of acute renal failure, you might never get them quite back to the baseline renal function that they came in with. And it's the same here. You might never get them quite back to what they were, but you should expect some improvement. And I think we've touched on all of that enough. Good. Is there any questions about acute confusional states? Cool. I'll hand over to Dr. Dooley for analgesia.